Good evening, everyone. My name is Neville Hatfield. I am speaking to you guys tonight from New Jersey, where I live, about simplifying our armamentarium. Before we get started, I do want to talk about that I have a financial interest with this presentation. It's sponsored by Tokuyama, and Tokuyama is nice enough to allow us to learn a little bit tonight. So we'll thank them a lot for that opportunity. So about me, like I said, I live in New Jersey with my wife, my daughter, and my two rescue dogs. I work in Mahwah, New Jersey, which is northern Jersey, outside of New York City, about 45 minutes. And I write for Dental Economics in a bi-monthly column entitled Along the Way, where I write about my experiences in clinical practice and any products or techniques that I really find that really help us out in day-to-day life and struggles that we come up with. So that's kind of my interest. Objectives for tonight are four things. Is the first one is reviewing bonding generations and kind of identifying bonding systems that can be both flexible and resilient and what's out there right now. The second one is weighing the pros and cons of permanent cementation options and what's the most common, and is there truly a universal permanent cement? The third is utilizing current composites to simplify our anterior and posterior restorations. And the last one is, finding a solution for difficult denture patients, which all of us have. And is there truly a permanent soft reline material that we can do chairside that we don't have to constantly send out to our lab for? So kind of get starting on our first bullet point here. This is talking about the modern enamel dent and bonding generations are bonds that we use every day for resin composite dentistry that I hope most of us, or not all of us, are doing. The current market availability for bonding generations are 4 through 7 with the possible 8th generation. So just so you know, a higher generation does not necessarily indicate a better performance. Generations of enamel dent and bonding describe usually the steps involved and how many bottles are involved rather than the strength of the bond itself. Earlier generations, so the 4th generation is considered to have more steps than the 7th generation would. Market improvements and inclusion of monomers has allowed even our newest bonding agents to be compatible with almost every material. That being said, there are current 4th generation bonding agents that exist and are good with everything, and there are even 7th generation bonding agents that work with almost every material. Being able to kind of break these down and understanding what each of them do, you should be able to identify the ones that which generation that you're currently using in your dental office. Starting off with the biggest two criteria is whether or not we're using etch and rinse technique or we're using a self-etching resin bonding agent. So 4th generation is what we call the 2-bottle bond system. Acid is our 37% phosphoric acid that we use, followed by a primer, and then followed by adhesive that's usually light cured. 5th generation simplifies this by basically making a 1-bottle bond. The primer and the adhesive are in one bond or one bottle, but we still use the etching or the acid step. 6th generation kind of got rid of having to use that blue gel, and now we've turned over to having the acid actually included in the bottles. So 6th generation goes back to 2 bottles and did not require a separate etching step. And then 7th generation, which was kind of the all-in-one, all-inclusive, all of everything, meaning that you just use this one bottle, you scrub it on the preparation, and now you have etched, primed, and adhered the bonding agent to the tooth. Now, this 8th generation, and the reason why I put it in pink up there, is that this is the big question mark. So what makes the 8th generation the 8th generation? And that is that most 8th generation bonding agents that are out there are marketed to basically say they are compatible with both self-etch and etch and rinse techniques, meaning that you can either use the acid that's already in the bottle itself in a 1-bottle system, or you can do a separate etching step, whether or not that's selective etching or total etching. So 5th generation is probably the most common and the most popular that we're still using nowadays, meaning that we still use the blue etch and then we follow it with a 1-bottle application with a light cure to harden the bond. So examples and companies of each generation here, there's tons of companies out there with all great bonding agents. 4th, 5th, 6th, and 7th generation are all very common. So if you look at the top, OptiBond FL from Kerr is one of the main ones when we use it in our scientific literature. as well as G2 bond universal is from GC, which is a great bond that's come out from them that is still using the fourth generation, two bottle system there. And then if you go all the way down to the bottom, you can see a popular one, which is 3M Scotch Bond Universal, which is one of the very popular seventh generation self-etch bonding agents. So just kind of breaking it down a little bit further, the fourth generation is where we kind of talk about, this is, fourth generation was actually the first introduced, and that's about where the nomenclature really starts, is that fourth generation is just the earliest of these, but we still utilize the three separate steps. So introduced in the early 1990s, we use it as the gold standard for our scientific research, meaning that if you are looking at adherence of cements onto certain types of materials like zirconia or any scientific literature papers, they're most likely using a fourth generation bonding agent. Like I said previously, each of the three steps see three separate components, and the hard part about this fourth generation is that more steps obviously can introduce more error, especially as we have hard isolation cases. Fifth generation is, again, like I said, the most popular. Our first bottle, first moved to a one bottle primer and adhesive. I use the one step from Bisco pretty often in private practice right now, as that's what we have in the office. And the great thing about this is that it simplifies the procedure, right? You use your 37% phosphoric acid, and then you follow it up with the bonding agent, air thinning, and then light curing on these. And that helps reduce error in application because it's two steps, right? The sixth generation bonding agent was introduced in the year 2000, and this is where we kind of started to step away from using the phosphoric acid. We try to include that in our actual bottles themselves. So if you look at a bottle and it says SE on it, that's an indication of self-etch, meaning that this is either a sixth or seventh generation bonding agent. So if you have a two bottle system that says SE, that means it is a sixth generation bonding agent. And if you have a one bottle that says SE on it, that is a seventh generation. The really, really cool thing about the sixth and seventh generation self-etch bonding agents is that they basically reduce post-operative sensitivity to virtually zero, because our etching was self-limiting. There was no more human error. As soon as, a certain amount of time passed, there's no more etching occurring from the acidic primer in the actual bottle itself. So what I highlighted in pink in the bottom is still a bigger thing that you have to pay attention to. I'm sure that many of you, if you have a certain type of bonding agent, they say to use something called a dual cure activator. And what this dual cure activator is that if you're using any type of resin composite that is self-cure or dual cure, also known as core buildups, right? Or adhesive resin cements, they need to have dual cure activator either in the cement or the buildup, or you need to have a separate step for this. So when we're talking about seventh generations, one of the big ones, I believe Scotch Bond Universal now has it included in the newest iteration of it, but many of those seventh generation ones still, you have to really pay attention to whether or not you need a dual cure activator. So if you don't know, you should ask your rep about exactly what that means. So why the dual cure activator needs to exist is that the pH of these bonding agents is very low. It's below 3 pH. So what that does is that actually deactivates the initiator component, which is something called an aromatic tertiary amine, and it inhibits the polymerization reaction of the resin composites, which then obviously reduces the polymerization reaction and actually weakens the effective bonding to dual cure and self-cure resin composites. So the big question here, is there a true eighth generation? Technically, if you look at it, there's no true eighth generation bonding agent if you follow the current naming standards or the naming criteria for resin bonding. So instead, what truly exists is improvements on each component of our bonding systems and what manufacturers can do to remove steps in those bonding protocols to basically make it more predictable and a little bit more straightforward with less steps and less things to think about. So what they can do is remove light curing component. They can remove the need for dual cure activators. It needs to be compatible with both etch and rinse and self-etch techniques. It also needs to have a removal for a separate primer for indirect restorations, meaning that those monomers or those MDPs or anything like that that allow us to bond to either ceramics, metals, or zirconias need to be included in a bonding generation if it's not included in the cementation portion. So can we really simplify resin bonding application, but also maintain strength and versatility? And one of the great things is that Tokiyama has come out with a few years ago something called Tokiyama Universal Bond. So you can see this is a two-bottle system, A and B, and what they did and were able to achieve is that they eliminated these extra steps of compatibility between different materials. You don't need dual cure activators with this material. I guess I'll go through this. So it's compatible with self-etch, selective etch, and total etch techniques, right? That's one criteria. It's compatible with all light cure, dual cure, and self-cure materials without the need for those dual cure activators. It's also compatible as a primer for all indirect restorations, which are silica, zirconia, or metallic based, meaning that these can act as a primer or as our silane for things like silica based or lithium disilicate based restorations. It actually eliminates the light curing step. This bond does not require light curing, and it actually eliminates the 20-second scrubbing period. So many of us, if you're not spending those 20 seconds scrubbing your bonding agent, which most manufacturers have anywhere from 15 to 20 seconds of scrubbing, then you're actually not following the directions to the T, meaning that you're actually weakening your bond iatrogenically or self-caused. So like I said, Tokiyama Universal Bond eliminates the scrubbing period, which is great. And the best thing about it maintains its strength and long-term stability. Now, mind you, this chart is from Tokiyama and their R&D data. They're separate one, but this chart I think is really nice because you can look here at some very big name bonding agents from other companies and certain things that they do or can't do. And those caveats you'll find at the bottom left of the screen. So one of the more popular ones, like I said, was Scotch Bond Universal. If you use it with if you can see there, the caveat with the 1 star says it needs a dual cure activator. So for indirect restorations, primer for prosthetics, or any other self-curing resin composites, you need to have that dual cure activator. As you go through these other ones and these other bonds, they each have some drawbacks. Now that being said, just because these bonding agents have drawbacks does not mean that they're also not great products. They are great products. Tokiyama has just been able to eliminate all the stress of thinking about whether or not you know that it's compatible with the material that you're using. So again, comes in a 2-bottle bonding system, and the way you actually use this is that before you apply it to anything, you put a drop of bond A and a drop of bond B in one well. The ratio is supposed to be 1-to-1, but it is very flexible. It has some leeway there, so if you accidentally drop in a little bit more, that's okay. You quickly mix it up. You apply it to the integular of your restoration if you're using an indirect restoration, or if you're doing a direct restoration like a resin composite in the posterior, you can scrub it right into the dent right after that. All you need to do after that is air thin it for 5 seconds on light air and then 5 seconds on medium air, and then you are ready to go. There's no light curing needed, so that saves you anywhere from 10 to 20 seconds. So this is kind of going to our second objective here is what we can do to simplify indirect restoration, permanent cementation protocols. So if we're talking about a permanent cement, we're going to need to have ideal characteristics, right? So these are all characteristics. If we can have all of these or most of these, then we're doing very well with our permanent cement. So one thing we need to think about is good biocompatibility, meaning that our body does not react to the presence of any extra cement, so you don't get gingival irritation or inflammation. It has a long working time, but on the caveat of it also having a short setting time, meaning it can't sit around in a gel phase or a non-solidified phase for a long time. It needs to have low solubility, meaning that over time, our saliva is not supposed to wash out the cement, kind of like you have with some older cements, which I'll talk about later. Low film thickness is also something we need, especially if we're talking about something like cementation of something like a veneer, something that's very thin in and of itself. You can't have really thick cement in that area, but you also need to have the strength along with that low film thickness. The lower film thickness, what that means is the better it's able to flow and the less cement space you need between your restoration and your tooth, meaning that your restoration will be stronger. Caries prevention potential is something that we really need to talk about because certain cements are actually inclusive of things like fluoride, so glass ionomers and resin modified glass ionomers, and actually some resin cements have the inclusion of these cavity fighting ions, which are very important to prevent recurrent decay at that bond area. Something that would be ideal is a chemical bond to the two structure, right? That's what we get with our resin cements. And if you're going into biomaterials here, it needs to have elastic capabilities, meaning that when you're chewing and there's that thermocycling and all those things that naturally happen in our oral environment, the elasticity of our permanent cement should be such that it can take a lot of wear and tear. So think of a car tire. We want a car tire and we don't want an old rubber band, right? We want a car tire that's going to be tough, that's going to last for tens of thousands of miles before it needs to be replaced or repaired. Plastic deformation resistance. So plastic deformation is the point at which some material irreversibly deforms under some pressure or stress. So having that ability to resist that deformation and be resilient is something very important with cements. Again, for the same reason of wanting a long-lasting cementation or cement in our restorations. It needs to have acceptable strength and toughness. Same thing as the two above. We want it to last a long time and we want it to adhere to the restoration to the tooth for a long time. A major one is color stability, especially if we're talking about something like veneer cementation or in the anterior. We don't want to have, that amine degradation that happens over time with some dual cure resin cements, which some companies have figured out how to reduce almost minimally. And I'll talk about that a little bit later. Color variability is very important. Sometimes you need to use cements in order to block out colors that are not ideal on the stump shade, or you need to be able to, maintain a clear cement if our restoration and our underlying tooth structure has had our lab make a beautiful restoration. We don't want to alter the color of our restoration or how it looks. A big thing is going to be moisture tolerance, right? Moisture is always something we're finding in the intraoral environment, so you want to avoid that. Minimal steps for application is a big one, right? The more steps you have, the more complicated it becomes, the more error you can possibly introduce into our cementation steps. And the last one is a multi-material compatibility, meaning that it needs to work with almost every material that we have. We need it to work with gold. We need it to work with a PFM base metal or semi-precious metal. We need it to work with zirconia. We also need to learn to have it work with lithium disilicate or some resin composite lithium or silicate hybrids that are out now. So I'm going to talk about the two main cements here, which is resin modified glass ionomers and resin cements. Those are probably the two main ones that 95% of us are using. The older cements, such as zinc phosphate and zinc polycarboxylates, are still used and still great cements, but I think the other options between RMGIs and resin cements are much better. So if we're talking about the characteristics of these two, a resin modified glass ionomer can only lute restorations, right? Luting restorations is using the inherent characteristics of our preparation to adhere our restoration to the tooth. So I always like to think about putting two glass slabs together. If you have nothing in between, those glass slabs can slide past each other. But if you put a drop of water in between those two glass slabs, you have those that water kind of using its forces to basically hold those two together. That's what luting will basically do. RMGIs have a higher solubility in the oral environment when set. They do not set almost completely, so you can have some washout with RMGIs. The strength of these cements is moderate, right? We have some higher strength cements out there. Is technique insensitive, meaning these are easy to use, right? They are squirt and cement, right? You put them in there, you slap them in there, and they will do a good job. And for most of our cases in the oral environment, they will do a very good job, as long as our preparation is such that it can support it. They are more moisture tolerant in general than resin cements, and they have a bioactive component, which means that they have that fluoride release. And there's even some other types of glass ionomers or glass silicates that end up releasing fluoride or phosphate or calcium that are out there in the market as well. Resin cements are, ones that we can both lute and bond restorations. It's the same idea of using a resin composite. they can lute and bond. And bonding is using both a micromechanical and a chemical adhesion to achieve, restoration to tooth joining. So it's useful for both our retentive and non-retentive preparations. So it's a good choice for us if you have a 25-degree taper on your crown prep, right? You're going to need something with a little bit more oomph to it to really hold that restoration on at the tooth. In general, these have the highest strength of cementation by far. They are heads and tails above of any of the other cements. They are moisture intolerant during some cementation. So again, there are certain cements out there that manufacturers have come up with to increase the tolerance of moisture. But again, these become a little bit more technique sensitive when you compare it to something like an RMGI. So an RMGI, again, easy to use as a bioactive component, moderate to low solubility in the oral environment, improved moisture sensitivity, low translucency, low post-op sensitivity, which is a big one for us. The cons are, it only lutes medium tensile strength, and it's not indicated for many high glass ceramic, hybrid ceramic, or low retentive restorations. Basically, our lithium disilicates, our veneers, or some of those hybrid ceramics that are now out. Resin cements are the next category that I want to kind of dive into a little bit more. So there's multiple varieties and shades available, which is a big one, right? And the varieties kind of come in two flavors, so dual cure and light cure varieties. So light cure only varieties are typically ones that we use for cementation of anterior restorations where our curing lights can penetrate through the material we're using. Dual cure has a self-cure component and then actually has that chemical cure or time cure component to it. And then we get into the variety of adhesive versus self-adhesive varieties. So when I was talking about the bonding generations, this is where I'm talking about these resin cements, including some adhesive capabilities within it, right? Sometimes we can simplify our cementation protocol by using it or including those bonding properties within our cements themselves. And the best thing is that these things can have almost any shade, and including translucent shade, meaning that you have such variability in these that you can basically almost choose any color that you need. Once these are set, they have the lowest solubility in the oral environment. They've got a high tensile strength. They're the only cement capable of true adhesion to tooth and restoration, meaning that, the hydrophilic tooth has that bond put in place, and then you can all of a sudden have that hydrophobic bond to the actual ceramic or tooth itself, and you can kind of join those together, right? This is the bipole kind of thing we're talking about, especially if you think about like a cell wall, right? The same concept applies to resin bonding. It is the most variable in practice, meaning that you can use it in most clinical situations. Again, big con here is that these can be highly technique sensitive. So I like to talk about this rule of thumb sometimes with if we have any dental students in listening right now or any newer people. The rule of thumb is for if you have a dual cure resin cement, you're going to have two tubes mixed together. That means it's dual cure, right? Component A, component B mixed together starts some kind of chemical reaction. Versus if you have one tube, usually it means it's light cure only, right? Dual cure resin cements have the highest amount of clinical usages. You can use them in almost any clinical situation. The one big con with them is that they can have some color instability due to, like I said previously, the long-term tertiary amine interaction of the self-cure, meaning that it's going to kind of pick up these stains over time. Again, not with all resin cements, but a lot of them do. Light cure resin cements are only allowed for restorations that we are confident that our light can pass all the way into that area. And this is especially important when we're talking about things like aesthetic areas. You could even go so far as to call light cure resin cements sometimes if you're talking about biomimetic dentistry. Biomimetic dentists actually use warmed composite to lute a lot of the restorations together, which I think is incredibly cool. And you can obviously read up on that. Color stability with these is long-term is great because our photo initiator, which is chloroquine something or another, is much more stable. So we don't have that kind of color instability that comes with everything else. Adhesive resins, like I said, on average, these are the highest bond strengths, but they also come with the highest technique sensitivity, often with more steps involved. They also come with the most post-op sensitivity. And these really should be used when we're requiring our bond strength to overcome retentive form or poor preparations. Self-adhesive resin cements are a newer iteration of adhesive resin cements, and they are great. Some of the newer ones are really strong as well. These are squirt and shoot and cement, right? moderate to low post-op sensitivity because they have that that bonding component within the resin cement itself. These are excellent for hard to reach areas. So for example, post spaces or cementing in a post into a tooth, self-adhesive resin cements are really, really great for that. Examples of these, if you look on these lists, is you can probably pick out, these are some of the big names in here. You can probably pick out a few of these that you either recognize or you use in clinical practice. For example, on the adhesive resin cement side for my veneers, I really, really love Ivoclar's Verilink Aesthetic. LC means light cure. That is for veneers and or other preparations where I know my light can penetrate through the material. Super strong, very low film thickness, great stuff. And on the right side, another favorite of mine in the self-adhesive resin cements is GSM1 all the way at the bottom. Really great stuff by GC, as well as some of these other ones are also really great by DMG and 3M. So again, any of these have excellent and fantastic clinical performance. Again, all this comes with what drawbacks do each and every one of these have that we are trying to overcome? The things I talked about, that long list of positives, right? And that's where Tokuyama's SSM2 kind of comes into play, right? This material is an adhesive dual cure resin cement, which with universal application ability. So what they've been able to do is maximize the pros of adhesive dentistry and minimize the cons. Aesthetics of the cement are high with low to water absorption and it becomes hydrophobic once cured, significantly reduces the risk of marginal discoloration. So you can actually use this in the anterior for those anterior restorations and not have to worry about stains from, heavy stain things, coffees, teas, certain types of spices. And then when you pair it with their Tokuyama Universal Bond, this application is super simple and it does really become universal, right? The bond, in addition to the cement, and use both of those at the same time, can basically be used for any indirect or direct restoration. They are compatible with every metal, every zirconia, every ceramic. And then what these two in conjunction allow for is a minimized inventory, which is a main thing, right? A lot of us who are practice owners are worried about overspending on inventory and having things expire. With this, you can basically use them in almost every situation, and you're probably going to use them up before you have to throw them out. So this case was actually done by my boss, Dr. Wexler. He was kind enough to let me observe and kind of document his case. This is using SSM2 and Tokuyama Universal Bond, and these are kind of going through the steps a little bit here. So here we have number 11. I believe the patient broke his previous restoration or cracked it. So this is a replacement of an Emax crown that was placed. And as you can see, the patient has some anterior restorations in 7 through 10, as well as 12 and 13, or I guess just 12, are in Emax as well. So we're using a total etch technique here. You etch for the 15 seconds, you rinse and you dry the restoration. Over here on the right, you see one of the wells. As you can see, even though we have 2 bottles of bonding agent that we have to mix together, you actually move it into one. And you see it has this kind of cool blue color, which most of our bonding agents are yellow, right? Those yellow in our bonding agents can actually also discolor some of our restorations. You just mix it together and you apply it to the tooth. And the best thing about it is you apply it to the tooth and you air thin it. There is no light curing necessary. And then you can even take another brush and you can put on the intaglio crown, and that primes or silinates the intaglio of all ceramic crowns. You could also do this with a metal PFM, and you could also do this with zirconia, and it would work just as well, and actually you would have a chemical adhesion. And the last thing you do, like I said, you just air thin it. And then this is where you kind of test out to make sure everything is completely dispensed. You'll see here, this is actually the clear or translucent version of the cement. So when it's first dispensed, it has a little bit of an opaqueness to it. And then you just place it in, and then you can actually push it down, and you see you have a nice thin layer of cement all the way around the tooth. And then you can actually spot cure this, and then you can actually kind of peel it off in a gel phase. So you spot cure this for, I believe it's 2 to 3 seconds, and then you're able to peel it off like, almost like a sticker all around the edge of the tooth. And you just clean it up. And what you end up with is, a very nice, very simple, straightforward restoration and cementation. As you can see, the color stability is great. You can see that we've got a really nice restoration here from our lab which is really great. And then this is case I'm about to show next here is a case that I did that came in yesterday. So we have this debonded crown lay that I had to deal with on an 85 or 84-year-old patient of ours. And the issue here is that you can kind of see some decay on the mesial and distal here, right? I believe this is number 15 crown lay that kind of came off. And then once you see here, I kind of followed the same steps as we did previously, right? I cleaned the intaglio crown of old cement. I, air abraded everything. I re-etched with hydrofluoric acid to get, back down to the base ceramic there. And then I followed the same cementation protocol that we just did in the previous case. I did a total etch technique. I used Tokuyama Universal Bond with translucent cement, and then there you can see, and then if you look on the x-ray on the very bottom right there, you can actually see where I had to take away that decay. If you see where that thicker area of cement is on the mesial, that's where I kind of had to use my round burr to kind of eliminate that decay. And I knew I got all the decay because I always like to use caries detecting dye. Kind of moving on to our third objective here is kind of shade picking, right? Shades are always hard to pick. So I like to say this, pick a shade, any shade, right? You get teeth like these and these are a nightmare, right? You've got either decay that you have to deal with or you have to deal with a big class 4, anything like that. This is so stressful a lot of times because a lot of us don't carry, say, shades A1 through D4 in our office. So what can we basically do here? So kind of talking about, picking shades. So composite resin chemistry is so advanced in today's clinical environment that it's, it can be utilized to create biomimetic restorations that even when we look at them, we can't see those restorations. Strength, stain resistance, polishability, ease of use are all aspects which we have basically become very small differences between composites and composite brands. So that's a difficult area that we you can't set many restorations apart or many composite resins apart with that. But here, what we can still set apart a lot of composite resins apart one is using hue, value, and chroma, which is the shade of a tooth to consistently and effectively do day-to-day clinical dentistry without having thousands of dollars worth of composites sitting in a drawer. So going back to biomaterials again, hue, chroma, and value are basically what brings up shade and our tooth shade. And just a quick review here, hue is the inherent color or tone of an object. Hue is the reds, the blues, the yellows, the greens, the purples, the oranges, right? That's hue. Chroma is a saturation of this color. So how much green, for example, do we have right now in these dots right here? So you go from a lot of green, a lot of saturation of that color to almost no saturation in that color. And the very bottom is value, which is the relative brightness of a color. So how dark or how light it is, irregardless of hue or chroma. So what does that mean for us in dentistry? So this is something called a Vita 3D Master Tooth Guide. If you guys don't have one of these are really excellent to have, especially if you're working with a lot of aesthetic situations, because this takes the A1 through D4 Vita Classic Shade Guide and, kind of even makes it a little bit more valuable to us in dentistry. So as you can see here, the top says bright to dark. That's going to be our value, right? That's our value component of how much light or darkness is inherent to this. The next one is chroma, which is how much actual, red or yellow is actually in these teeth, right? Either pale or very intense. And the very bottom down there is our hue or inherent color. So our yellowish to our reds, which most of our patients have. Now, what I really would want to have if I'm a clinician is kind of having a chameleon, right? A chameleon that can basically blend in with almost everything and then not have to basically sit here and stress out about exactly what I need to pick and what shade I need to pick and mix and do all these other things. So for a day-to-day clinician like myself, one of the most useful products I have found is Omnichroma. So Omnichroma was our first universal composite, which actually mimicked our normal two shades from A1 to D4. And how they did that is they use these super nano spherical fillers, which actually, borrow colors that are refracted from the actual tooth itself. So the great thing about Omnichroma, like I said, about most composites, it still has that excellent handling, polishability, and strength that is the same or above many resin composites on the market. But the best thing about it is it reduces inventory and chair time, and it takes out the guesswork of shade mimicry and aesthetics. So it actually comes in 5 variations now. The first one is packable, and there's something called a packable blocker, and then flowable, flowable blocker, and then a new flowable bulk fill, which I really like. And I'll talk about what the blockers do in a sec. So Omnichroma is indicated for all class 1 through 5 composite restorations. It's strong enough to do that, right? You can use it in the class 2 as much as you can use it in a class 4 in the anterior. Omnichroma blocker is used as a supplement when we have to block either heavy stains inherent to the tooth shade. Say, for example, if an amalgam stained the tooth, right? You want to block that dark discoloration out, you can do that with the blocker. It can also provide shade matching in areas of large class 3 or class 4 restorations. So if you have a big chunk missing out of a class 4, you could put the blocker on the lingual side or the palatal side of the restoration to really kind of help block out what the Omnichroma would do, which is actually pick up the color from the mouth behind. And it's available in both those syringes and those PLT or those single-use compules. Flowable is the same thing, same indications. The flowable that they've been able to do is actually keep the strength up with these, and I think the filler percentage is very close to that of the packable or most packable, so you can actually use it for any restoration you want. And you can actually do large restorations, and I'll show you that later on, a large restoration done in just flowable. And the newest iteration that they just came out with last year is Flow Bulk. It's a very low viscosity, so you got to be careful with that. It's not as viscous as some of the other flowable, so it flows much easier. It has low volumetric shrinkage, which is what we need with bulk fill composites, so we don't have shrinkage stress in our restorations. It maintains the aesthetics, polishability, and strength that we can expect from a packable composite, as well as it's indicated for all things. So a brief look at this is that you can kind of see the guide here. You use it the same as you would almost any resin composite. You use it in 2mm increments. You can use it in the anterior or the posterior, and it'll actually pick up the color from the tooth around it. Now, if we're using something like a blocker, you can see here in the top screen in the second window in, it says blocker flow is placed right over that amalgam discoloration like I was talking about previously. And if you look in the bottom, kind of right in the middle, you can see on that lingual or the palatal shelf where the blocker is used to actually block out the color from the mouth or the tongue. And that actually allows us to use it as a tooth backer there. So here's my first case that I've done, which is shade A1, and I used both Omnichroma and Omnichroma blocker in this one. I think this restoration turned out very well. This is an immediate post-op, and you can see the size of this restoration, right? I used blocker on the lingual, and then Omnichroma, normal Omnichroma on the facial, and look how it polishes super nice. Here's another one I did. I actually used all 4 iterations of Omnichroma, the original Omnichroma iterations. And so you can see an original pre-op and then a post-op too. So I had class 5s, I had a class 3 here, there, and I actually had a class 4 in this. So this one turned out really well. And if you notice in the top right, I list the shades there that you can actually look at. Next one, here's another case I used, and this is where I used Omnichroma Flow and Omnichroma Flow Blocker. And what I want you to pay attention to is number 6 there on the left side of the screen. You can see that's probably a bigger restoration. You can see how well these turned out really nice. And this is immediate post-op, so you can see my gums are kind of torn up here. Here is another case that I'm really kind of proud of, and I did a great job on, I believe. I actually had this published in Oral Health magazine in Canada, talking about a diastema closure using, again, all 4 iterations of Omnichroma. So you can see this is the pre-op here on the left, and then if I take that away, you can see all that gingival irritation from a poorly contoured restoration. So I kind of did this gull wing preparation here. And then that's I believe a 1-week post-op on the left, and then you see that's a 6-month post-op 6 months later when he was in the hygiene room. So you can see that this blended in very well. His gingiva healed very nicely, and we actually have a nice blend in there. And then, believe it or not, a lot of these incisal edges of these composites I also fixed on 7 and 10, which most of you probably didn't notice too much, but I actually ended up fixing those as well. Again, I used all 4 iterations. I like to use flowable, especially on the margins on areas like this. It flows very well. So those are all my cases, but I kind of want to show you other clinicians because I'm not the only one that can get great results. Anyone can get a great result. So here you can kind of see number 7 is a bit short on the left side. And then on the right side, you can see a class 4 that Dr. Bob Lowe did, and this is a shade B1. I believe he just used normal Omnichroma with Tokuyama Universal Bond. The next one here is from Dr. James Che. I think this is a really cool one. He actually took out an amalgam some stain, and then you can see how characterized he could make this. And he used just omnichroma flow bulk here. So this is pre-op and immediately post-op. Here's another one, a big lingual class 3. We've seen a lot of these in some of our older patients. Look at all that amalgam staining. And this one, he just ended up using just omnichroma, and this is from Dr. Peter Oster. Here's another really cool case from Dr. John K. Sullivan. You can see how much rampant decay there is and how big those restorations would be. But if you look on the gingival margins, all those stains have basically disappeared because omnichroma uses the two structure underneath to basically fix this. And the great thing about this, these big restorations were done with the omnichroma flow and the flow blocker. Moving on to our last learning objective here is, who are some of our hardest patients to deal with? It's always the denture patients, especially those patients, because those expectations that patients who are new to dentures have are so high. They think they're going to work just like their natural teeth would. So expectation setting is one of our most critical aspects, especially with denture patients. They're expecting them to fit well with zero adjustments and to function just as regular teeth do. And as you and I both know, that is not the case. And even temporary flippers, for example, in the anterior, waiting for, those implants to kind of integrate, take a long time. And one of my favorite, and I wrote about this, I believe I wrote about this in dental economics already, is soft reliner tough from Tokiyama again, is really, really cool. So what this stuff is a chair side silicone-based soft reline material, and it comes in two formulations, soft and medium. And if you look on the right here, you can kind of see their indications. So immediate after surgery or tooth extraction on an immediate denture, they're great. Over implants, they're great, right? You don't have as much pressure on it if you have something soft on top of it. And then you can see in the bottom there, people who have sharp ridges on the bottom. They have atrophy and they can't deal with hard acrylic pressing way down in their vestibule. Major undercuts right on top of tori, over denture, pain relief. They help improve suction, and it's really, really, really great for first-time denture wearers, especially if they're an immediate denture. And the best thing about this is these chairside relines are about 1.5 to 2 years of service life. The great thing about this is that they maintain their softness. These do not harden with time. So something like Co-Soft or Co-Comfort will harden and get hard as acrylic over time. In this case, it does not. It's a silicone-based thing, as well as it's also really great at resisting bacteria, plaque, and odors. So we've all had those Co-Comfort patients come back and it just smells, right? It's nasty. With soft reliner tough, you don't really have that. It offers a superior strength and durability, and it has excellent adhesion. When I tell you this adheres really awesomely, it really, really does. And the best thing about it is it's got a really easy chairside application. So we don't need to send this off to the lab to have them do. And if you ask for a soft reliner or silicone reliner, most likely your lab is using a material just like this or is using soft reliner tough in the lab, right? Here's a case I did for a patient who is a cancer patient. Here I had already removed what was the old Co-Comfort, and that took me a while. You can kind of see some splotches remaining. And you can see how I prepared the edges and kind of took away some of the acrylic around the edges there. It's a really easy application. It's a squirt and shoot, just like you would any type of PVS or impression gun. And then they actually come with these polishing pumice sticks that allow us to kind of really help it kind of thin it out so you don't have any of these hard ledges. And when you look at it right after, you can see that you capture all the vestibules and the anatomy and everything. It fits very well. And it goes right over the lip of there, and these are extremely, extremely comfortable. And I actually relined both her top denture and her bottom denture with this. And if ever, all of us know, bottom dentures are a pain. So definitely should look into soft reline tough. So speaking of our objectives, hopefully I've hit all of them for you. I've kind of talked about all the generations of bonding, 4 through 7, and that number 8 doesn't really exist. That talked about the pros and cons of cementation options or permanent ones, and how close we can get to a universal permanent cement. The simplification of anterior and posterior composites with a universal composite like Omnichroma. And then also, like I was talking about, soft reliner tough and how that helps me deal with difficult denture patients and how we can have a more permanent soft reline of 1.5 to 2 years before you have to touch the patient again. And lastly, I want to thank you for your attention. And at this time, I'm going to kind of go over any of the Q&A questions that have kind of popped up, and then I'll answer any questions you guys may have. So let's start with the first one here. Bisco all bond and one step. I believe all bond is either a different generation than one step. I believe it's a seventh generation, which means that it's all in one bottle versus one step is the etch and rinse component of it. Where are those slides where we can access them? These are my slides. I don't really have these out available. You can, I believe, get the recording later on if you want to look at them, or if you want to look at the technique guides for any of these products I talked about, you can usually find them on Tokuyama's website. The film thickness of Tokuyama cement, I don't remember the exact film thickness of it. You have to forgive me for that. Okay, gold posterior crowns that are the most close adapted to the prep would need a very thin cement, not the usual 10 to 20 micron thickness. So yes, but you also have to remember something like a polycarboxylate cement or a zinc phosphate cement were very thick film thickness cement. So you have to realize that those were used in the past and they worked well with gold restorations when those were more commonplace. So you can use almost any current resin cement or RMGI with gold crowns and still have a good result. Someone asked, in the case of zirconia crown cementation, when is the best time to apply Tokuyama universal bonds? It contains primers, so isn't it better to apply before trying in the oral cavity? So you're correct. Anytime you try in a crown, you're going to have natural phosphates in the saliva adhere to the integrity of the crown. So it's very, very important that you have some kind of cleaner agent that is placed onto the integrity of your restoration, whether or not you use something like IvaClean, right, which is from Ivaclar, or if you use micro etching or sandblasting, that's very, very important to get rid of those phosphates before you apply these universal bonds. So what I like to do is I like to try and check my contacts, check my margins, take a bite wing if I need to check my margins, mesial and distal. Sometimes I'll adjust my bite before I cement, but most of the time I do it afterwards. Then take it out. Then I will usually Concepsis onto Concepsis is a chlorhexidine containing cleaning agent, I believe made by Ultradent, that I used on the tooth itself. Then I etch, then I apply Tokuyama universal bond to the tooth, right? Air thin it, and then I'm ready, the tooth is ready to go. At the same time, after my assistant cleans the integrity of the crown, I go in and they put on Tokuyama universal bond and I'll actually air thin it for them with my air water syringe. Then you put something like your cement in between there, and then you cement and do your regular cementation protocol there. So that the best time to apply Tokuyama universal bond is after you've done your try-in and after you've cleaned your crown. So we use Omnichrome. The only issue it has is low radio opacity. That is true. I believe the newer formulation, like the Bocal, has a slightly higher radio opacity. It is a little bit of a frustration, but in reality, it's not as big of a deal for me. I don't find that I have an issue with that. Okay, is really composite and syringe versus comp have the same characteristics of flowability when do you use them? Okay, so composite in a syringe, like a flowable syringe, is going to be more flowable. It's going to be less viscous, right? Something like a compule that you push out of a composite gun itself is going to be not viscous at all. It's going to have high viscosity. So the characteristics, more or less, and how they act in the mouth and how we benefit from them are the same. The problem that you run into is when you need to use them. So those cases I was showing you previously of different restorations using flowable versus packable composite, you have to make that judgment call and see what works better in your hands. Because sometimes, putting packable composite on a class 5 in gingiva that's very angry is very tough to do with packable composite, but much easier to do with a flowable composite, like the flowable versions of this Omnichroma. Do you suggest mouth guards for bruxers after fixing their incisal edges? Absolutely. You can basically tell who those bruxers are by, they have all those jagged edges along the front. Okay, is eugenol still a concern in adhesion? Yes, it is. Eugenol still is. Most of our temporary cements no longer contain eugenol. You still can buy eugenol-based temporary cements, or people who like to use eugenol in as a medicament in pain relief and root canals. Is still concerned. Has not gone away. Can patients use denture glue with the reline material? Absolutely, they can use it. Would you please show the slide for the denture reliner. So it's from Tokiyama. It's called Soft Reliner, SOF Reliner. You can find it on their website. I don't have control of the presentation anymore, so I can't show that. How did you achieve the embrasure on the diastemic case? Looks great. So I actually ended up using a sectional matrix band and was able to close the space there and use that to kind of create my embrasure form. So I finished almost one tooth completely, and I like to do a reductive technique when I do preparations or cases like that. And so what I do is I finish the whole case, put all the composite where I need to go, and basically finish the whole tooth like 95% of the way, and then I work on the other tooth. And then that way I'm able to basically put the embrasure space exactly where I need to put it. What is your thoughts on Panavia SA? Panavia SA is an awesome cement. Curare makes wonderful, wonderful stuff. Panavia V5 is also a really great adhesive version of Panavia SA. Again, they are great materials. Who makes Soft Reliner Tough? Does it come with adhesive? So Soft Reliner Tough is made by Tokiyama. It does not come with denture adhesive like that the patient would get over the counter, but it does have actual primer that you put on the acrylic of the denture itself. Do you apply chlorhexidine scrub to crown preps prior to cementation? Yes, I do. How do you have denture patients clean after a Soft Reliner Tough? The same way they would clean a full acrylic denture. Can you apply Tokiyama Universal Bond for Soft Reliner? So you don't actually use, that's what an indication you don't use it for. So in the Soft Reliner Tough, you actually end up having a primer included in the kit, and it actually also comes with a removal bottle as well. So if you need to replace it in the future, you can actually squirt it underneath and almost peel it out in one step. You don't have to sit there and fight with it like you would some other reline materials. I have one question with the Universal Bond. I bought about 1 year ago, and I'm a big fan of SLA composites and want to try the bond age. If I remember, you have to keep it in the fridge or cold place, which seems impractical to keep in the operatory. Has that requirement changed? So technically, no, that requirement hasn't changed. The reason why they say to put it in the fridge is that it increases shelf life. So what you can do is you just have your assistants, you put it in the refrigerator at the end of the night when you're done, and then you take it out in the morning, and it can stay out all day without affecting its effectiveness. You just have to put it back in at night. That's how I do it in my practice, and that's okay. Okay, you said the service time for Soft Reliner is 1.5 to 2 years. Do you just do it again with the same process and the same time setup? Do you move it just like you would CoSoft? So you don't remove it like you do CoSoft. Like I said, it comes with its own bottle to remove, and then like I said, it peels off super duper easy. You put it under, you peel up an edge, you put this little material underneath there, and you almost peel it off like it's a sticker on top of the denture. It's super easy to do, much quicker to do as well. You don't have to grind it out at all. Do you think one wing Maryland bridge wing on 6 ponting and made by zirconia can bond well, or better with metal wing? Which bonding system do you suggest for zirconia wing and for metal wing? So in theory, there's something called APC bonding for zirconia, which is air abrasion, prime, and then cementation. So the studies on zirconia bonding show that over time zirconia bonds do degrade. I don't know exactly the statistics behind that, but if you're going to do Maryland bridges and things like that, sometimes I'd probably do with a metal primer instead, but you could probably have both and have a really great result. I think the biggest thing with Maryland bridges is you have to make sure that your excursives and how it works can actually work for the patient. 2 questions. Would you use a flowable bulk versus regular composite? Specifically, the depth is 3 millimeters. So I do use a small one with low fission seal and pulp that in a box of a class 2. So basically with a flowable, I am the same as you. I like to put a little layer of flowable down, make sure it gets into all the nooks and crannies, and then I cure that. And then if I bulk fill over that, then I'll do increments. So if I'm using omnichromal flow bulk, I do the same thing. So yes, you'd get the same result if you use the bulk flowable, but again, like I said, I would still, instead of just doing one layer, I would do it in like one layer first, and then you can bulk fill the rest. Do you ever heat up your flowables? Yes, I do. I was actually talking to one of my good friends about this. Pacdent, I believe, has a really cool composite heating gun, but it's like $1,000, so that's a little bit too rich for my blood. What I ended up using is a coffee warmer. There is a Instagram called Dental Tube on Instagram that is by the UAB biomaterials section of the dental school down there, and they have such awesome information on there. And I actually bought the coffee warmer. It's a little like a coffee plate, and that's what I use to heat up my composites now. Okay, we use all these Tokiyama products to tell my tire friends that they retired too early. So Omnichrome is a godsend. Yep, Tokiyama Omnichrome is a godsend. It's really, really awesome. Do you pack cords for cervical margins? And if so, does it interfere with bonding agents? So it depends. I don't typically like to pack cord because of the little pieces of fraying material. What I actually do is I take a piece of Teflon tape and I roll it up, and it becomes like a pseudo um, cord. And I can still pack it with a plastic instrument into the sulcus, and I can do my whole bonding protocol, and I just peel it away, and it doesn't adhere to the bonding agent. The impregnated cords, yeah, no, same thing. Like I said, I usually put some, either 1 to 50,000 epinephrine right into the gingiva there, and then I do it, or I just put 1 to 100,000, and then I use that Teflon tape. With a 3-gram omnichromal blow close on average, how many MODs can you do on an upper first molar? I understand depending on the size of the cage, just a ballpark. It honestly depends. I don't typically find myself using bulk flow that much in like large cases like that. I think if it's hard isolation cases, I have some other materials I like to prefer to use. One of my favorite ones is from Pulp Dent called Activa Restorative, which is a really, really great bulk flow restorative that actually has a lot of bioactivity component in it. But I have used Omnichrome in the posterior like that. So a 3-gram syringe like that, probably not that many. So for me, I like to use those in those premolars a lot because the color match is just awesome and it works super, super well there. This cement can be used for crown and bridge or over implant. Yes, you can use it for that as well. You can use it for implants. What is your protocol for bone bonding onlays? So onlays, I like to do immediate dentin sealing, IDS, which is utilizing, you etch after you prepare, you etch, bond, then you put a little bit of flowable composite over, cure that, put a little glycerin over that, cure that again, and then that gets rid of the oxidation inhibition layer, and then you're able to then temporize, and then you can just cement right away if you have a mill or a 3D printer in your office. Does the reline material wear away in a few weeks? No, it lasts 1.5 to 2 years. Can you use composite warmers? Yes, you can. With Tokiyama composites, yes, you can. You can use composite warmers with almost every composite on the market. Can I use Panavia SA for zirconia wing or metal wing? That really depends on what the primers are in the actual self-adhesive for it. If you're thinking about strength for doing something like that, I would look at adhesive cements with the correct primers. So there's something called MDP10, which is a primer for zirconia that you need to basically make sure that Panavia SA includes if you're going to use Panavia SA. Strongest temp cement without eugenol. There's one called Olympian. I don't remember who makes it. I also really, really like GC temp cement. I think it works really well. But Olympian is one of the ones that I usually have to cut off my temporaries because I just can't pull them off without having that issue. If a crown falls out with resin cement, sometimes it's very difficult to remove the cement from the tooth structure. Is there an easy way? You can use an intraoral air abrading unit if you have one, or you can basically use a little trick. You can actually take a black light or UV light, and you can go very slowly with a round burr, right? And you can kind of chip away at that composite. And each time you think you've gotten it away, you just use the UV light, and then it basically shows up or fluoresces the resin cement, and you'll be able to find where leftover resin cement is. So you would use now only the bulk versus syringe. Okay, hold on. So you would use now only the flowable bulk for a 3 ml restoration versus syringe. So the flowable bulk, like I said, I like to use it in smaller preparations, especially in premolars, which is really great. In the class 2, would you still use the bottom of the box sealant, pulp dent, or the flowable Tokiyama Invincible than the sealant? I actually do use, I still use a lot of pulp dent products, including their Activa Presto. I find that the flowability of Activa Presto is a little bit too viscous for me, so that's why I like to use my composite heater if I'm doing like a large posterior restoration. But I also like to use Tokiyama if I'm using a low. Everything depends on the patient and whether or not they're high caries risk. If they're high caries risk, I use Pulp Dents Activa Presto because it has some bioactivity in it. If it's the 35-year-old that's had one restoration in their life, I'm going to use Tokiyama flowable and their bulk flow almost every time. I believe I've answered all the questions. Thank you guys for your attention. I hope you guys learned something. And if you have any other questions, you can always reach out and email me. My email is hatfielddmd@gmail.com. Thanks so much. Have a good night, everyone.